Left off with was we were finishing puberty, and then we were starting reproductive anatomy and physiology. So we were focusing on the male. We're going to finish the male and go into the female reproductive anatomy and physiology. So this is a sort of mid-sagittal section or cut which splits the right into the left side. We're kind of looking right into the middle, and we went over some of these structures last time, but just to remind you, we've got the bladder, okay? We've got the testes, which is down here in the scrotum. Testes, the epididymis, the vas deferens. Oftentimes textbook will call it the ductus deferens, but I usually call it the vas deferens, or the vas differentium. So the vas deferens, which goes from the epididymis, tracks all the way up around the bladder to the back of the bladder, and then goes through this sort of swelling or ampulla, merges into the ejaculatory duct, and that goes into the urethra. Okay, so all of this is, here's the membranous, the prostatic urethra, membranous urethra, and then the actual spongy urethra that goes through kind of the spongy connective tissue of the actual penis. Then it opens, bless you, then it opens at the external urethral orifice. There's three major sets of glands that help to produce fluids and components of the seminal fluid. So urine, of course, comes from here, and this urine coming from here will just go right from the bladder into the urethra. So there's one common duct for seminal fluid and for urine in the male, okay? So it goes, there's three different sets of glands. There's the prostate, which is right here, and we're gonna look more at the prostate later because this is a sort of one of the more rising, more commonly occurring cancers in men, prostate cancer. And enlarged prostate is one of the first signs of that typically. So the prostate gland, we've got the seminal vesicle gland that's off right here, and it dumps right into the ejaculatory duct. And then we've got these cute little glands, pea-sized glands, they're called bobourethral glands, and they dump right into the spongy urethra. Those three sets of glands, seminal vesicles, note these are paired because we're just looking at one side, right? Seminal vesicle, prostate gland, and bobourethral gland. Those are all making different components, fluids that contain water, sugar, salts, nutrients, calcium, things that are going to protect and nourish the sperm as they are traversing through the ducts and then making it to perhaps the female reproductive tract, okay? So we've got also the external genitals that we went over last time, the prepuce or the foreskin, which is often, most of it is removed if the male is circumcised, the glans penis, which is the end, the shaft of the penis, and then the spongy, it's called the corpus spongiosum, the spongy tissue that surrounds sort of the urethra and makes up the bulk of the shaft. Okay, so those are the overall parts of the gross anatomy. So if we look really closely in at the testes, we're looking at one testes. So this is a testis, and then here's the epididymis. The epididymis is this comma-shaped structure where the sperm that are matured actually leave, and then they mature further in the epididymis. And then they exit this duct. These have snaking, coiling ducts that are all inside of them. This actually leaves and it goes up through here, through the vas deferens. So this specifically, we're looking at the epididymis, this structure right here. The testis is right here, and this is actually where sperm are being developed and they're forming. So they're undergoing meiosis and forming right here in the testis. The seminiferous tubules of the testis. And if we look at one of these, they're divided into lobes. They kind of go and they come back, come back. So if we look at one of those lobes, it's right there. Seminiferous tubule that goes all the way through and then kind of comes back to the root testis. So they're being produced, developed, and made here. They move into the epididymis, mature further, and then they can be stored and mature in here for many, many days before they leave and they go out through the vas deferens. All right, so some of the structure, the ultrastructural components here, or microscopic. So if we open this, we section this, and we look at the actual tissue inside of the testis, this is a cut through one seminiferous tubule. We're just looking through a piece. And under the microscope, we can see here's kind of one seminiferous tubule, like a cross section going right through tubule. And the cartoon version of this is right here. Sperm are actually developing and undergoing meiosis and differentiating or turning into full-fledged sperm right in this space right here. So out in the outer part, you've got these cells that are kind of right up against the edge. They're big, they're kind of fat. Here's one right here. These are spermatogonial stem cells. They're all along the edges, okay? These spermatogonial stem cells are the ones that are giving rise to all of these rounds of meiotically dividing sperm throughout the male's life, beginning at puberty, not before that, beginning at puberty and then through adult life. Sometimes sperm counts will go down with age, and they often do, but the male will still make sperm. So they'll still have seminal fluid that has sperm in it, just reduced counts typically. So as they're developing, they undergo meiosis, okay? And as they move, they get pushed and they move towards the center. So what you'll end up seeing is tiny little nuclei. They're like little heads. They're the heads of the sperm. And it almost looks like little hairy, kind of looks like little streaks or little hairy parts. It's actually the sperm with their developing tails as they're getting pushed and moving to the center of the lumen. A lumen is a hollow filled space, right? So the seminal tubule, they develop from the edge and they move to the center, so that usually, even under the microscope, we'll see little fibrous stuff and it looks hairy. My students usually say, "Oh, it's hairy, what's all that hair?" Those are tails. Those are the sperm tails that are actually right in the middle of the lumen. When they get fully matured, they get pumped, sort of moved by hydrostatic sort of fluid motion. They detach, and then they move through the testis and going to the epididymis. So if we blow this up, we're looking at a little section like right here. We're looking at the edge of the seminiferous tubule. You've got spermatogonia, or spermatogonial stem cells, which are kind of right down here. And they're the ones that are going to divide and lead to all of those developing sperm. Ultimately, up here with their little flagella kind of inserted into the middle or dangling into the middle of the lumen. Something else important, there are cells that are outside of the tubules. Okay, so this is all the action of what's going on inside the seminiferous tubule. Out here, not in the tubules, so the cells that are surrounding the tubules, and these are all nuclei, so these are individual cells out here, those are actually called Leydig cells, and I put right there, I highlighted that in bold and underlined it in the text. I left some of these figures of the text. This is from a supplemental textbook, Human Reproductive Biology, and I really like it a lot. So if you look on our Moodle site, I put a lot of chapters that are going to be upcoming, coming from that textbook. So I made copies, electronic copies of the chapters, like chapter 3, chapter 16, chapter 8, and for you to sort of look through. But these are right from that textbook, and the text for it, the legends, are usually really helpful. It gives good descriptions. So out here, these are called Leydig cells. Leydig. They're outside the seminiferous tubules. They're very important because these are the guys that pump out and make testosterone. The majority of a man's testosterone comes from these interstitial cells, or these cells that are outside of the seminiferous tubules, and they make testosterone. The other type of cell that's really important is called Sertoli cell. I know these are weird names, but this is just, they were named by anatomists, physiologists. The Sertoli cells are actually cells, it's kind of hard to see, but all of this right here, I don't know if they even label it. Yeah, they kind of do. In purple right here, this is actually a Sertoli cell that's kind of wrapping around in purple. It's wrapping around all of those developing sperm that are undergoing meiosis, okay? So the Sertoli cells are big. Their nucleus is right here. It kind of wraps all around these developing sperm undergoing meiosis. Sertoli cells are like, I would say they're the nurse cells, they're the support cells, okay? And they actually bind to the testosterone that's made out here. They bind to the testosterone and they keep it high, surrounding the developing sperm. And they also help to support and nourish and allow the cells to undergo meiosis and grow and stay protected. Now remember, the gametes, are they genetically identical to the person that they're being developed in? No. Are they very genetically different? Yes, they're very genetically different. It's like a different organism almost, right? It has half the amount of chromosomes, genetically shuffled, so the man's immune system would actually attack their own sperm if they weren't protected by these nurse cells, these support cells, that sort of surround them and protect them from the immune system and the person's antibodies and white blood cells. Does that make sense? Because they are not genetically identical to the man's cells himself, okay? So Sertoli cells, nurse support cells, they keep testosterone high in there, they protect them, allow them to grow and develop. Leydig cells make testosterone, keep androgens high in the body, and surrounding the developing sperm. Okay, so I just want to emphasize Leydig cells, they're out here in the interstitial area outside of the tubules. Sertoli cells are enveloping and surrounding the developing sperm. Oops, this is an actual image. This is a really neat SEM, a scanning electron micrograph, showing one of these cross-section of a tubule. You can see the tails from all the newly made meiotic sperm, and then the spermatogonial stem cells out at the edge. And then as they develop, they get sort of smaller and smaller, right? They lead from 1 to 4. So these are the developing spermatids that turn into full-fledged sperm in the center. So then they get moved by fluid action, and they get transported to the epididymis, the next spot. So as they develop, you've got the stem cells, the spermatogonial stem cells. Now remember, the feature of stem cells is that they can self-renew, they can divide sort of endlessly, and they have the potential or the ability to give rise to other cell types. Those are the 3 major important characteristics of stem cells in your body. So that means this guy self-renews, and when it divides, it makes another one of itself, so the stem cell stays behind. If it just divided into 2 sperm-forming cells, you just lost your stem cells. You can never make any more again. A man can keep making them until they're 90, theoretically, right? Because the self-renewing spermatogonial cell stays behind. One generates a type B daughter cell, and the type B daughter cell will actually give rise to the process of meiosis, where it's a primary spermatocyte which divides through meiosis 1, and then it's a secondary spermatocyte where it divides through meiosis 2. Now we have early spermatids, and that means they're basically getting smaller in cell size, and they're starting to elongate and grow a tail. And notice they eject or they lose most of their cytoplasm. This droplet, cytoplasm droplet, will actually be exuded and kind of released. So they are light, streamlined, narrow, they can swim, and they're sort of programmed to try to swim and find and fertilize the eggs. So what we would say is this is meiosis, early spermatogenesis, birth of sperm, early spermatogenesis, and then the late spermatogenesis. Sperm biologists will actually refer to this as spermiogenesis, where they actually grow a tail, get rid of their cytoplasm, and kind of condense down their nucleus in their head. Kind of the final preparations and packaging for being a full-fledged spermatozoa or sperm. Okay? So early spermatogenesis, meiosis is happening. Now this is just maturing. Basically the chromosomes have been split, right? And now they're all haploid, there's 4 of them, now they grow a tail. So if I enlarge that, just that sort of spermiogenesis section, some other key things happen in getting a normal sperm that's able to fertilize. So you make 4 from 1, that's meiosis 1 and 2, right? Primary spermatocytes and secondary spermatocytes and the spermatids. The cute little spermatids now, they end up growing something called an acrosome or an acrosomal vesicle. It's basically a membrane sac, an acrosomal little vesicle or sac that ends up right around the nucleus and in the anterior tip of the head. So it's inside and it's right there. So you've got this little acrosomal vesicle, and what's in there is enzymes that allow the head of the sperm to release a whole bunch of enzymes that allow penetration through the egg. So these enzymes, when they get released on contact with the egg, they will rupture. It actually undergoes exocytosis. So remember we talked about exocytosis and then endocytosis. The acrosome, there's receptors that trigger and get bound when it binds to the egg outer membrane. And when that happens, it triggers the release of the enzymes, and it makes a hole. It basically makes little holes that the sperm can start burying and binding into the plasma membrane of the egg. So they lose their cytoplasm, they eject it. They don't want to be heavy, they want to be light and streamlined. They get rid of all the excess. They have a ton of mitochondria around the mid-piece. That's why the mid-piece looks fatter, because it's filled with all these mitochondria. What do mitochondria do? Why would they have sperm have a ton of mitochondria? They actually spiral like little kidney beans around the mid-piece like that. Why would sperm have a lot of mitochondria? Powerhouse, energy, so they have to swim. Ultimately, when they get deposited in the female reproductive tract, they have to swim. So they need to be able to sustain and generate a lot of ATP and do a lot of work, because they're moving, they're actually swimming. All right, so they grow an acrosomal vesicle, they grow a tail, they get rid of the cytoplasm, they have a lot of mitochondria that assembles around that mid-piece. So they're just fast little swimmers. And I almost think of these as like, these are like a swimmer's cap. Okay, they're like little swimmers with their little swimmer's cap, and their little swimmer's cap on contact with the egg will exocytose, release enzyme, and allow that sperm to start to bore through and then bind with the plasma membrane of the egg and then achieve hopefully a successful fertilization. Hopefully, if that's what the person is wanting. Because I never know. A lot of people are like, oh, no. So depending on, if the winning sperm fertilizes or not. So in the epididymis, it's actually the comma-shaped structure that extends out from the testis, wraps around the testis, and then merges into the vas deferens. It's 6 meters long if we uncoil it. You know how many feet is in a meter? About 3, 18 feet long, just from the tiny little comma-shaped epididymis on the back of either testis. So stretch it all out. Same thing with the seminiferous tubules, really, really, really long. Stretch it out. It's many, it's like dozens of feet long. Okay, so 20-day journey for sperm to move through the epididymis. So they get made, they move through the seminiferous tubules, they end up in the epididymis, and they're maturing there, they're gaining additional sort of maturation, and they are stored and kind of move through there. It takes almost a month. So they go through chemical changes that actually give them the ability to swim. They give them the ability to undergo the acrosome reaction. That means when the head reaches the egg outer envelope, it allows the acrosome to undergo exocytosis. So they have to gain the chemical ability to do all that. And to fertilize an egg, they have to mature. So they're made in the testis, but they're not mature. They've got a tail, they've got the acrosome, they're little swimmers with the swimmer's cap. They need to gain the biochemical changes that allow them to fertilize, do the acrosome reaction, and reach the egg. Okay? So again, here's the epididymis. So we looked at that, Here's where they actually will traverse further and they'll go up the vas deferens. And then here's another view, sort of looking at the vas deferens, the ejaculatory duct, and the urethra. If we track it back, here's the epididymis. So sperm are being created and made in here. This whole process takes about 75 days. So from being made, undergoing meiosis, spermatogenesis, spermiogenesis, getting a tail and an acrosome, and then maturing biochemically in here, and then being stored, it's about 75 days. So it takes, it's about 2.5 months. So epididymis, vas deferens, ampulla, and then dumps in through the ejaculatory duct to the prostatic urethra, and then the spongy urethra, and then it would be out the external urethral orifice. Anytime you see orifice, that means opening. Orifice is an opening of the body, right, somewhere. All right, and here's the prostate, and here's the bladder. So we're looking at frontal view, sort of straight on some of these internal reproductive structures. And some other structures, to look at this in a slightly different view, we're looking at the spongy tissue that makes up the shaft of the penis, the prostate, and then the urethra, urethral orifice. If we do a cross-section, and this is kind of right through here, if we do a cross-section, it'll look like a circle, right? So this is a cross-section right through the shaft of the penis. Here's the top, the back, here's the underside, or the bottom, the ventral. We have the spongy urethra that's surrounded by spongy tissue called the corpus spongiosum. It's just spongy tissue surrounding the urethra. And then you have two big bodies. They're called corpora cavernosa. So we can see them here on either side. They're here, and they're here, and right here, they're right here. And to me, I know this is weird, but under the microscope, I've looked at a lot of these histology of these under the scope, and a lot of these tissues are really pretty. This one always looks like a fly to me. It looks like a fly face. And I can't help it. Even the real tissue under the microscope, I'm like, there's my fly. Okay, it looks like a fly. It's got eyes and a mouth, a little head. Okay, so this is the skin. This is the corpus spongiosum, the spongy tissue surrounding the urethra, which exits at the orifice. And then the corpora cavernosa, these are cavernous sort of tissue. These are the erectile bodies, or the erectile tissue of the penis. This is what allows the penis to get engorged or erect. Fluid actually comes in here. There's deep arteries in the middle of the corpora cavernosa, and there's a deep dorsal vein and a dorsal artery that are right here. So those actually, what happens is blood will come into that area. Blood fills these arteries, right, and veins, and then basically sort of gets pinched off so it can't leave that area. And the tissue sort of swells with fluid, and the arteries and veins sort of swell with blood. And those are really considered the erectile bodies of the shaft of the penis, okay? So fluid comes in, arteries, blood flow comes to the area, and it kind of enlarges in size. Okay, so those are the corpus, or the corpora cavernosa. are those erectile sinuses. They're basically sinuses in space that can actually fill up. Okay, so that's what we call the erectile bodies. Whoops, back up. Okay, so to get rid of that, we're looking at the endocrinology of the testes. So we talked a lot about puberty and the hormones that are involved in puberty and sexual maturation. Basically, to review, we've got the hypothalamus makes GnRH, that starts getting pulsed out. The pituitary, the anterior pituitary, makes FSH and LH, so LH and FSH. These show the specific target cells. I would say this is a target cell of LH, and a Sertoli cell is a specific target cell of FSH. That means they have the receptors for those specific hormones. Okay, so this is showing how this hormonal cascade affects the male reproductive system. LH binds to and activates Leydig cells, causes Leydig cells to start making testosterone. So remember those Leydig cells surrounding the seminiferous tubules out at the edges? They're the ones pumping out the testosterone. They're making androgens. So LH causes Leydig cells to make testosterone. This is easy. I think of LL. Luteinizing hormone affects the Leydig cells. Has them do their function, and their function is to make testosterone. So they'll start making out androgens like testosterone. FSH will specifically target the Sertoli cell, okay? And the Sertoli cell will start converting testosterone into estradiol, bless you, and it also makes androgen binding protein. Androgen binding protein is a protein that binds to testosterone and keeps it high in that area. So sequesters it, hangs on to it. Remember, testosterone is a fat, it's a lipid, it's a steroid. It comes from cholesterol. It doesn't go with water. So androgen binding protein from Sertoli cells will help sort of hang on to testosterone and keep it high where the developing sperm are located. Yes? Okay, so this is sort of overall looking at from brain to gonads, how we're actually getting the downstream response of the hormones that are made and how that impacts the meiosis of sperm. There are sort of different responses of testosterone and estrogen or estradiol. This is to show that these sex steroids, they're cholesterol based, they're made from cholesterol, but they're very similar. They can be converted to each other. And this is actually in the testes in the male, this is what happens. A lot of times, some of those cells are actually converting testosterone into estrogen. So the male body actually sees estrogen, not at as high of a level as in a female body, but they're converting it. There are enzymes. One is called aromatase, and another one is called 5-alpha reductase. And we will come back to this later, because we have a whole section on developmental sex development disorders and intersex. I had a few of you asking about intersex. What's the difference? What is that? We have a whole lecture that we're going to focus on, and this is one of the examples of what leads to a situation where someone is intersex. So testosterone is converted by different target tissues to either estradiol or something called 5-alpha DHT, or dihydrotestosterone, or dihydroxytestosterone, how do you want to say it? Dihydrotestosterone and estradiol. Now, if you look at their structures, you don't have to be a chemist. I did teach you a little bit of chemistry in here, but I know you don't have to be a chemist to see this. You can look and go, okay, these all have 4 rings. Looks a little bit like cholesterol. Remember cholesterol. These are nonpolar compounds, right? These are ring structures, so they're fats. The only difference here is we have a double bonded oxygen, right? And a hydroxyl or an OH up here. This one has the same thing, it just has an additional hydrogen. That was hydrogenated right there. That makes it, in this case, 5-hydroxytestosterone. Estradiol, all we have that's different here is instead of a hydroxyl, an OH, instead of the oxygen, it's a hydroxyl, an OH. So there's hydrogen that's added, so there's no double bonded oxygen. This functional group difference right there is really all that's happening. Tiny, tiny functional group difference converts major biological functional differences in their activity and what they do to different cells, okay? And notice this kind of goes, testosterone is the major circulating androgen in men, but it can be converted in target tissues to either estradiol or to other steroids like 5-alpha dihydroxy. And then what these can act on are specific receptors on other cells. So they can act on estrogen receptor alpha estrogen receptor beta, or the androgen receptor. So they can go on and act on their specific receptors and cause changes in lots of other target tissues. Now, I think one of you are doing HRT, you're doing hormone replacement therapy as your research project. Yes? Who's doing hormone replacement therapy research project? Over here? And then who else? Who's the third person? Oh, she got it. She just left. She was just here. Okay. Oh yeah, that's right, I heard the door. Okay. So there, you guys are going to talk all about this, and you're going to go into a very specific area. So I'm just giving the little general lowdown. You're going to hear lots more from this group when we get to the research projects. Anabolic steroids. This is not hormone replacement therapy. This is individuals that are illegally using these drugs to do what? To do drugs, but bulk up. Yes, thank you. Not just to do drugs, but to do the drugs to get at the side effect. And the side effect or the result of these is to bulk up in muscle. Muscle mass, lean muscle mass, and lots of it. It really helps to do that. And a lot of people, the numbers of the rates of doing this are quite high, actually. A lot of individuals that are just really avidly sort of working out and getting big muscle mass, sometimes these rates of anabolic steroid use are fairly high. So there is drug testing in sports and athletics and the Olympics and all these things. They want to make sure that people aren't blood doping or roiding. You know, they're doing roids. They can do it in pill or injection form. So if someone does this when they're young and they're going through puberty or they're sort of in the adolescent phases of life, it can cause things like hair thinning and baldness, acne, really increased acne, more than the normal amount in puberty. And by the way, acne is due to androgens. Acne, it comes specifically in men and women. Androgens, the effects of testosterone and androgens, those levels start ramping up. It causes excess oil production. So a lot of people get a lot of acne during that time. Steroids disrupt the function of the brain's limbic system. So the limbic system is involved in emotional part of the brain, in mood and memories and feelings and emotions. So the limbic system is specifically affected, causing mood swings. Imbalance of hormones, so they mess up the hypothalamus, being able to interpret and start the endocrine system pathways. So the hypothalamus gets messed up because it's getting bombarded with androgen, testosterone. So remember we talked about negative feedback inhibition? If you have too high a super physiological dose, which these often are, getting bombarded with a really high level of androgens, that is going to inhibit centers in the brain, right? Remember we talked about negative feedback inhibition. So those things are going to get imbalanced. So oftentimes boys can develop breasts. Also, if you think about testosterone gets converted by aromatase into estradiol. So in those target tissues, it can convert to estrogen. So ultimately, and later on, breast development or gynecomastia can happen. In girls, it can cause deepening of the voice and facial hair because they're getting exposed to testosterone, right? Anabolic steroid or androgen, a version, a derivative of that. And the reproductive effects on both sides are infertility. So it can affect the functioning of the gonads and meiosis, development of the sperm, development of the eggs. Heart attack, stroke, atherosclerosis is also higher increased risk for doing anabolic steroids. And then the bones, basically the bones will sort of stop growing so these individuals in adolescence can risk stunted growth because high levels of androgens and estrogen cause bone plate growth fusion. Remember I said that? So it causes bone growth, and then at a certain level over a certain period of time, it causes fusion of the growth plates. So the ends of your bones have growth plates with cartilage, and they keep growing and extending. You get exposed to a really high level, it stops. Cartilage cells die, the bone fuses, now it's all bone, you don't grow anymore. Okay, so it causes growth plate fusion. Liver cancer, tumors, and cysts are also higher in anabolic steroid users. Also infection for things like HIV, hepatitis B, hepatitis C all go up from unsterile sharing of needles and when they do it kind of in a recreational way together. So a lot of really negative side effects and on the reproductive system as well and the endocrine system. Now in an adult where this is more prevalent, I think there were studies a couple years ago they looked, it was 4% of high school seniors age 18 had tried anabolic steroids. So it's about 4 out of 100 kids that are about 18, which I still feel like is sort of high. It's not that common, but there are people that try it. They're usually doing athletics, they're doing sports, they're trying to bulk up. It makes gaining the muscle mass quicker. But the problem is it's got all these other side effects. So severe acne on the face and back, as I mentioned, headaches, baldness, so hair loss, high blood pressure and heart disease. So specifically associated, it increases LDL, it decreases HDL, puts you already at risk for atherosclerosis, heart attack, stroke, heart disease, so blood clots and strokes. Causes impotency and reduced sperm counts. So ultimately, the testes and where testosterone is getting converted to estrogen, and it's helping with that whole process of spermatogenesis, it's getting blasted with super physiological doses. So that actually kind of ends up shutting down the system, making less sperm and causing stuff like erectile dysfunction or impotency. So the testicles shrink, they atrophy in size, so the scrotal and testes area shrinks. Sometimes it's associated with enlarged prostate, gynecomastia, so afterwards, after prolonged use, it can cause breast development or breast tissue development, mood swings, urinary problems. In women specifically, so these are the sort of the adverse effects of using anabolic steroids, which by the way is not as common in women as it is in men, but there's still adverse effects. Reduced breast size, so breast tissue itself will atrophy and shrink, so losing some of the fat and gaining sort of more muscle. Enlarged clitoris, increased facial hair and body hair, deepened voice, and menstrual problems, if not complete amenorrhea. Stop cycling, okay? Your system is getting bombed with androgens, and really it wants to have estrogen and progesterone with small amounts of androgens. Anabolic steroids are high amounts of androgens at super physiological doses that are outside of the normal physiology that your body would normally see. So that's why it has all these major effects on muscle and all these side effects. So some of the biggest things in my opinion are kidney disease and retention of fluids. That's bad. It increases the rates for retention of fluids in kidney disease. Your kidneys are going to hang on to excess fluid. That actually will specifically affect your blood pressure. If you're holding on to fluid in water, your blood pressure is going to go up. My phone is doing something. Oh, it might die. Oh, okay. High LDL, low LDL levels. So it messes with total cholesterol and the ratio of those important bad and good cholesterol levels. Atherosclerosis and high blood pressure, heart disease, heart attack, and stroke. So it's a lot of negative things that come from this. Now, I will say, in hormone replacement therapy, those doses typically are not like this. They're not super physiological, very high. They're done in a regimented, lower dose way and sort of systematically by a physician over time, depending on what the outcome measure wants to be. If the person is transitioning and they're trans and they are doing hormone replacement therapy and surgery, it's a very regimented way to do it. They're not getting blasted with anabolic steroids, okay? And if someone is menopausal or postmenopausal and having severe symptoms and has low to no estrogen, if they are not a major risk candidate, things like deep vein thrombosis and cardiovascular disease in their family, again, they'll do a low dose, sometimes they'll do a low dose estrogen replacement or hormone replacement therapy. So this is different than that. Okay, this is really high, it's illegal, high doses, high levels over time. And ultimately, we're talking about reproductive anatomy and physiology. Causes infertility. So it's blasting the gonads in the brain with high doses of androgens. So ultimately, counts go down, size of the testes atrophy, and you get